As you unshare your screens, I invite our next speaker to go ahead and share her slides. We are really, really excited to have Dr. Amitha Gumidyala as our next speaker. She is a clinical psychologist with niche expertise in GI psychology. Her skills and unique management options are truly game changers, in particularly for the care of our patients with functional bowel conditions. We're really excited for her talk today, where she'll be talking about practical ways that we can harness this brain-gut connection. So thank you so much for being here, Dr. Gumidyala.
Thank you, Dr. Patel. And first of all, I'd like to thank all of the course directors for inviting me to speak at this conference today. So first, no conflicts of interest, but my goal today in talking about practical approaches with the gut-brain connection is to review the biopsychosocial model of disorders of gut-brain interactions, provide a quick case and a summary of the psychological interventions used, while highlighting what pieces of those interventions could be potentially addressed by any provider in that patient's care. And then I want to end with a quick demonstration of an easy relaxation exercise. So of course, typically when we're talking about the gut-brain connection, it's usually in the context of disorders of gut-brain interactions, or what many providers still call functional GI disorders. And there's really been a move away from this term functional, just because it suggests that symptoms are not accounted for by structural or biochemical abnormalities, which is in contrast with organic conditions like Crohn's disease or ulcerative colitis, where you can really see those physiological abnormalities. So a functional diagnosis can sometimes lead patients to hear the message that since there's nothing organic, it must be all in their head. This is not only stigmatizing, but also not fully accurate. Research in this area has really revealed that there are some biological abnormalities, so things like immune dysfunction, altered gut microbiomes, things like that that can predispose a person to disorders of gut-brain interactions. Also, shifting this focus to gut-brain interactions, not only does it help destigmatize the disorders, but it also provides support for use of psychological treatments. So another thing that I'll mention that you are probably all very well aware of is that disorders of gut-brain interactions, or DGBIs, are some of the most common GI disorders in the general population. And in large-scale multinational studies, we actually see that nearly half of the general population will meet criteria for a DGBI at any given time, and these conditions frequently overlap. So these are just really very common presenting concerns in our GI clinics, as well as our primary care clinics. And this isn't even accounting for the number of people who might have a DGBI, but don't actually consult their medical providers and might just take over-the-counter medications. So the burden of DGBIs on our systems and the impact it has on a person's quality of life can actually be pretty huge. So I present this slide a lot, and it's really because it can be helpful to have a framework that conceptualizes the multiple and complex factors that interact and contribute to both the onset and exacerbation of a DGBI. So this biopsychosocial model really emphasizes the interactions between biology, so things like genetics and disordered gut motility, and behavior, so things like illness behaviors or symptom avoidance, cognitive processes like visceral anxiety or attentional bias, general coping skills, as well as environment, so trauma, stressors, even early life events. And a key component of this model that contributes to symptom exacerbation is dysregulation of that brain-gut axis. And this brain-gut axis really refers to that complex bidirectional communication between the brain and the gut. And the enteric nervous system is communicating directly with the brain through numerous nerve pathways. And stress and physiological or psychological factors can directly influence gut functioning as well. So things like motility and visceral pain levels through this pathway. And of course, all of this can contribute to the symptoms that patients ultimately experience. So again, it can just be really useful to understand this framework because it helps us as providers conceptualize these DGBIs, and it can help us provide some context to our patient for the interventions that are often recommended to treat DGBIs. And really, it can help set the stage for what interventions might look like if they do work with a GI psychologist or a mental health provider. So the psychological factors noted here are, usually the primary targets of treatment for psychological interventions like CBT or cognitive behavioral therapy and gut-directed hypnotherapy. And again, oftentimes our patients are hearing that they have a functional disorder and then they're referred to a psychologist. So it can lead to ideas about needing to work on more long-standing mental health issues stemming from early traumas, or focus on external stressors like relationship issues or family dynamics. But again, this framework can just help highlight the fact that those early life experiences, while they might impact the way people think and feel, it's really how they think and feel about their GI issues that's the focus of treatment in GI psychology. And the other thing too is that even if these psychological factors aren't playing much of a role when symptoms first develop, over time, things like anxiety or preoccupation with symptoms can really start to cause the symptoms to escalate from being mild to more moderate or severe. So again, this is just a helpful framework to put all of that into context. Okay, so now we've reviewed that DGBIs are very common, they are real diagnoses, and we have a framework for understanding the onset and exacerbation of these illnesses. So I'm going to talk about applying this information using a case example. So here we have a 53-year-old Asian American female who has a history of IBS. She has 3 episodes of diverticulitis diagnosed in the ED over the past 10 years, has hypertension and also 1 instance of pancreatitis, and it was found that she had a stone in her bile duct. So that led to her gallbladder being removed, and she also had an appendectomy and a laparotomy related to an ectopic pregnancy. She was prescribed Bentyl by her PCP, but she rarely took it due to concerns for intolerance. And she also reported a pretty significant mental health history of childhood sexual trauma and PTSD. So although she had engaged with mental health services in the past, it became pretty clear to both of us during our time together that she still had some ongoing symptoms of PTSD. So after she met with a GI provider in our clinic, she was referred to both me and our GI dietitian for nutritional counseling. So really quickly, I'm going to summarize her treatment here, and then I want to point out parts of her intervention that really can be, and in this case were, introduced by all providers involved in her care. So briefly, cognitive and behavioral interventions were used to help address symptoms of pain, symptom-related anxiety, hypervigilance, and attentional bias to even those benign gut sensations, avoidance, and then also regulation of autonomic arousal. And these techniques here are listed, and I really want to highlight psychoeducation and relaxation training. So these are 2 things that can be so helpful for patients who have something like IBS, and it can be relatively easy to deliver in a short visit. So with this patient, she came in with a very clear diagnosis of IBS from both her PCP and her GI provider. So when we met, we reviewed these symptoms and the criteria for IBS. And I also provided some education about the brain-gut axis using really patient-friendly language. So explaining how there is this constant bidirectional communication between the gut nervous system and the central nervous system. And sometimes that communication can be disrupted by lots of different things or a combination of factors. And in her case, we talked about the abdominal surgeries, inflammation in her gut, history of sexual trauma, and just general stressors. And when this disruption occurs, the brain can really amplify those sensations from the gut and can send inappropriate signals back down to the gut, causing the muscles in the gut to just function in less helpful ways. The patient also understood that although these factors from her past may have contributed to the onset of symptoms, she was able to see that other factors over time, such as anticipatory anxiety related to pain, hypervigilance around any changes in gut sensations, and even catastrophizing, all of those things contributed to symptoms worsening over time. And talking about some of these other factors also helped her link stress to symptom exacerbation. And in talking about these factors like anxiety and hypervigilance and catastrophizing and how they contributed to symptom exacerbation, provided the opportunity for us to talk about cognitive and behavioral interventions that are really aimed at modifying our thoughts, reducing some of that sympathetic nervous system arousal, and addressing avoidance behaviors. And that model right there is just sort of a brief summary of cognitive behavioral therapy for IBS. And if you have the luxury of having a little more time with your patient, you might even find it helpful to use a stress tracking worksheet like this one, just to help highlight those cognitive, affective, and behavioral processes that are occurring in response to perceived stressors. So again, this education piece can be so important because it really can provide reassurance to the patient that their symptoms are real and validate their experiences, while providing some insight into how they develop their condition and what might be making it worse or even just keeping things going. And of course, it offers some hope for addressing these symptoms as well. So in terms of her behavioral response to her symptoms, she reported often skipping out on activities like golfing and hiking, singing with her band, going out to eat, because she was so anxious about pain increasing or needing to use the bathroom regularly or urgently while she was away from home. She also described waking up in the middle of the night because of pain and then feeling panicked and overwhelmed with worry about what that pain could be indicating. And this did lead to some ED utilization as well. So one of the early techniques that we use to help address some of the physiological responses to increased stress, anxiety, and worry is relaxation training. So to get patients on board with why or how this might be helpful, we have to provide clear rationale. So often I'll ask patients to tell me about how stress feels in their bodies, and then talk with them about the stress response system or the fight or flight system. I share that when this system is activated, there are a lot of physiological changes that occur. So things like an increase in heart rate, the breath becomes more rapid and shallow, even increases in blood pressure and increases in muscle tension. And often with that muscle tension comes reduced oxygen in the GI tract, which can lead to people experiencing things like butterflies in their stomach or indigestion or even nausea. I also talk about how stress can cause a delay of gastric emptying and intestinal transit and can promote stimulation of the large bowel, which can of course lead to people feeling that sense of urgency and need to defecate or urinate. So relaxation skills are really presented as a way to modify this physiological arousal to help better regulate your stress response. And there are lots of different types of relaxation strategies that can be taught. So things like diaphragmatic breathing, progressive muscle relaxation, guided imagery. But the ultimate goal is to really help them to learn to activate the parasympathetic nervous system, the rest or digest part of the system, shift some attention away from the symptoms and worries about the symptoms, feel the difference between stress and tension in their body versus being relaxed. And there are some resources to help them with this practice too. So often I recommend breathe to relax and inside timer. Breathe to relax is a really very straightforward one, just focused on breathing. And that can be just a helpful app that they can use on their phone to get them started with diaphragmatic breathing exercises. So I'll actually do a quick demonstration on how I introduce diaphragmatic breathing. And then I think we should have enough time for me to lead us all in a quick breathing exercise. And this is one that I frequently do with my GI patients. So you can get a sense of what it feels like as well. So when I'm introducing diaphragmatic breathing, what I'll say is first, just put one hand on your chest and one hand on your belly and just take 3 normal breaths. Now, you might have felt that top hand moving the most. And when we're stressed, this is what happens. We engage more in that chest breathing with more tension in our bodies. And with diaphragmatic breathing, we're actually pushing that breath lower into our stomach, and the chest will remain nice and steady. And you'll notice that your lower hand will start to rise and fall with each breath. So you take a breath in through your nose and out through your mouth, slowing that breath down, really letting that air fill your belly. And as you exhale completely, your belly is going to let go of all that air and completely exhale out. You might notice that as your breath slows down, your inhale will be about 4 to 5 seconds, and your breath might be a little bit longer, about 6 to 7 seconds. So you really get that breath fully out. So that is the basics of introducing diaphragmatic breathing, and then actually lead them through a little breathing exercise together so that they can just get a little bit of practice, feeling what it feels like to take that slower, deeper breath and calm the body down. So if you're up for it, as you're listening to me talk, you can join me in this breathing exercise. And what I always say is that wherever you're sitting, whether it's on a chair, on a couch, or if you're lying down in bed still, just get comfortable. Get comfortable where you are. Really let that chair support your body without you feeling too rigid, but also not slumping over in your chair. And if you can keep your feet on the floor, that could be helpful just to help you ground yourself while you're doing this exercise. And if you feel comfortable, you can close your eyes while you're doing this exercise. If that doesn't feel comfortable, you can just find a spot on the ground or on the wall, something that just doesn't take your attention away too much, but something that you can focus on. Okay, so here we go. So first, just start by becoming aware of your breathing. Again, you can place one hand on your abdomen at the waistline and the other hand at the center of your chest. And without trying to change anything, simply notice how you're breathing. Notice where you're breathing from, whether your shoulders are rising and falling, whether your chest is rising and falling, or perhaps your belly is rising and falling. Just notice how your hands move as you breathe. Now notice the rate of your breathing. Are you breathing rapidly or slowly? Are you breathing deeply or more shallow? Now, as you slowly inhale, imagine the air flowing deeper into your belly. Feel your belly fill with air as your lower hand rises. Pause at the top of your breath, and then follow your breath out as you completely exhale. Slowly take a breath in, 2, 3, 4, and slowly exhale, 2, 3, 4. Let any tension melt away as you relax more deeply with each breath. Notice how the air feels as cool, fresh air enters your nose, passes through the little hairs in your nasal passage, reaches the back of your throat, and descends deep into your lungs. Notice what happens as that breath of fresh air enters your lungs. And notice what happens when you exhale. Feel the temperature of each breath. Cool as you inhale, warm as you exhale. And count your breaths as you breathe in and out. Notice your breath becoming smooth and slow. Feel your belly and rib cage expand outward with each breath. And feel yourself become more relaxed with each exhale. Allow your shoulders to become heavier with each exhale. Continue breathing slowly and gently. As you breathe, notice the cool temperature of the air as it enters your nose or mouth. And notice how the air becomes warmer as you follow it deep into your belly and out through your mouth. Continue breathing slowly and gently. Again, slowly take a breath in, 2, 3, 4, and slowly exhale, 2, 3, 4. Feel yourself become more and more relaxed with each exhale. And now as I count from 5 to 1, feel yourself become more alert. 5, bringing your attention to this room. 4, feeling calm and relaxed. 3, start to wiggle your fingers and your toes. And 2, slowly start to move and stretch your muscles. And 1, open your eyes, feeling refreshed and rejuvenated. So thank you for joining me on that breathing exercise. Hopefully that was relaxing and you got a sense of what that feels like, just slowing down that body and calming down that body. So really quickly, the take-home points are, the biopsychosocial model really helps explain DGBIs, and relaxation strategies can be really useful in reducing activation of the sympathetic nervous system and really are a core component of most brain-gut psychotherapies. All right, thank you.
Thank you so much, Dr. Gumidyala. Dr. Revely pointed out in the chat that what you walked us through is the treatment of choice for rumination, but I'd argue that it's the treatment of choice for daily living and something that many of us can incorporate into our daily routines. And